All right, I'm going to get started. See who shows up. How's everybody doing? Who's here? Are you guys? I've been asking you. You're fine. You're fuzzy. You're fine. You're not showing me you, but you know. Okay, so today we're starting cancer. I didn't bring M&Ms. I've been eating pumpkin pie and turkey, so I hope you all have a snack. I kind of modified this slide that heart disease and cancer are the number 1 and 2 killer, and COVID is now the number 3 killer in the US, and but we're talking about cancer today. We already talked about COVID, and maybe next semester it'll be easier to talk about. So I'd like you to, I didn't put down, I knew I forgot something. So please open your poll app, and we'll have current events and some discussion questions, and then you're going away for a couple days. I'm not sure what's going on. I have not been doing the weekly roundups because, like you who are overloaded with work, I'm just overloaded. So just pretend you never had them. So if you were looking forward to them, you don't miss them, and I'm okay with that. But if someone wants to volunteer to do it. Okay, how many posts do I have? 17. Oops. So I was playing with changing colors on this. So I'm not sure what stayed and what didn't. So we're going to see different colors on the backgrounds of the slides today. Okay. So do you folks know what a mammogram is? We're going to be talking about cancer. Oh, okay. So the top one says, yes, I do. And the bottom one says, oh, you can see it. Sorry. No, I do not. Since we're talking about cancer, I suddenly realized one semester that my demographic knows all about these things, but I should not be assuming that you folks do. So are we seeing an answer? Oh, I see. Yes, let's see answers. Okay. It's okay to not know.
Professor, I voted. I don't understand why it's not showing up. I don't know if anybody else did.
This one doesn't. These two are information only. There's no right answer to this one. Okay, so let me find my mouse. Okay. A mammogram is a screening test for breast cancer. We did talk about it briefly at the beginning of the semester, or when we were talking about Angelina Jolie and her BRCA mutation. It's when the breasts are compressed in between a camera unit and an x-ray is taken, and that can give you, it gives the x-ray technologist an idea of if there are any masses or if there's anything growing in the breast. A lot of times what happens is something may show up and you don't know what it is. You just know something's there, but until you look at it, you won't know what it is. And that's part of what the controversy is about some of these screening tests, is that many times the screening tests that suggest there may be something there, it turns out that there isn't. For example, if something shows up on a mammogram, you may need to the woman may decide to have a breast biopsy where they will take out some of that tissue to see whether or not it's malignant. 80% of the time it's negative. 20% of the time the statistics suggest that it is cancer. So, and that leaves women in a very difficult position. Do you know what a PSA test is? No, you're oh, wait, I want to show the responses. Oh, are you not seeing the responses? Do you folks see that? Oh, okay. So wait a minute. Maybe and you still don't see them because I told them to show up in white. Oh man. Okay. Wait a minute. Are you even registering? What I'm looking at on my screen? Well, I don't know what's going on here, but so 13 folks said no and 2 said yes. So PSA stands for prostate specific antigen, and it's a measure of an antigen in the prostate tissue. So normally you have cells, and this is women have the mammogram, men may get PSA tests, and cells in a prostate are healthy and usually organized in a tight pattern. Only a small amount of this antigen will leak out into the bloodstream. But with prostate cancer, the cells are disorganized. And that's what I talked about in the video. And what happens is that more antigen can leak out. And that leads to a higher PSA level. The problem with this particular screening test is that PSA can go up for a lot of different reasons, which puts men in the same position of wondering what to do with a screening test result that may or may not show cancer, and what do they need to do about it. So maybe we'll talk more about that, not in today's class, next class. Cancer is one disease affecting many parts of the body, true or false? I don't know why you're not seeing the answers. I don't know what's going on. Well, I'll just tell you, and I won't play with this toy again. 5, 4, 3, 2, 1. The answers on my screen show 8 said true and 6 said false. And the correct answer is false. Cancer is not a single disease, all right? There are lots of different types of cancer. In every tissue in the body, different tissues and different organs can develop cancer. And that's what this particular video showed, but it's not a single disease. We'll talk more about those when you get back, because that'll be fun. There are breast cancers, there are prostate cancers, lung cancer, but there are blood cancers as well. A tumor is always cancerous, true or false? Five, 4, 3, 2, 1. Okay, there are 2 people that said true and 13 that said false. The answer is false. And you may not remember this, although maybe I talked about it in class, but way back at the beginning. So yes, I cheated. I asked you a question from early on that we have cancer arises from mutations, right? But there are what are called benign mutations and malignant mutations. And I just have this here to use it to remind me to tell you that a tumor is a conglomeration of cells. But until you biopsy it, until you take the cells out, look at the tissue under a microscope and run tests on it, you don't know whether it's benign, meaning harmless, or malignant, meaning cancerous. A tumor is just a conglomeration of cells. I remember a number of years ago, my son had been hoarse for a long time, and it was just getting annoying. And he went to see a doctor, and they told him that he had a tumor on his vocal cords, which he had removed, and it was benign. And of course, being a mother, I was scared to death because that's my job. And I'll never forget when he called to tell me that he'd gotten the results. He said, well, it was a benign tumor. And he just said it really casually while my blood pressure, dropped back into normal range, because he knew the difference between benign and malignant, and he wasn't worried. But because I worried. He's fine. Eating a healthy diet and exercising regularly will prevent cancer. True or false?
Is it like will completely prevent it from happening or will like help your chance?
Word here is prevent. Sometimes I don't pay attention to my words. Here's a time when I am. Five, 4, 3, 2, 1. Okay, so the correct answer is false. And again, it's because of that one word. All right. Scientists have studied many foods, lots of dietary components with possibly associated with increasing or decreasing risks, but we can't say with any certainty that there is a food or a behavior. I will say, don't smoke, you'll die. But folks know, I know somebody who was in her 80s and was still smoking. So what was I going to tell her to do? Quit? She'd live longer. So, there are always exceptions. And this brings up, I have a good friend who works at Dana-Farber Cancer Institute, and they were having a webinar last week that I was going to watch. The name of it had to do with using diet and exercise and behaviors to prevent cancer. And I was very upset about using those words, and I didn't watch it, and I'll listen to it another time. But I asked her, I said, did she use those words and say prevent cancer? And my friend said yes. And I said, what happens to the person who watches their weight? Because diet, activity, and obesity, poor diet, lack of activity, and obesity are risk factors. I know that. But what if you have somebody who is at their desirable body weight, who eats well and exercises and gets cancer? Then they're going to blame themselves. Wouldn't it be a lot easier to just say reduces risk all along? So, but she's my friend. She did agree with me, and that's really all that counts. So, dysplastic cell changes are at higher risk of becoming cancerous. Cells that show dysplasia have a greater chance of becoming cancerous. True or false? Five, 4, 3, 2, 1. Okay, I have 13 that said true, which is the correct answer, and 2 that said false, which is not correct. So here we have a progression of cells, dysplasia or precancerous changes that can occur. So starting with normal, is there a question? Okay, so we have normal cells, and by normal, I mean you can see the nucleus, you can see the borders, they're well-defined. Then we have what's called hyperplasia. Before cancer cells form in tissues, they may become hyperplastic, which is an abnormal change, or they may become dysplastic. In hyperplasia, there's an increase in number of cells in the tissue or the organ that appear normal. So what we're saying here is that these hyperplasia, the increase in number of cells, is not yet, it shows that there's an increase in number of cells, but many times hyperplasia can revert back to normal. However, if it progresses to dysplasia, and in dysplasia, the cells look abnormal under a microscope. You begin to see abnormal looking cells, borders. You can't tell the difference between one cell and another. They may become what's called multinucleated, meaning an increase in number of nuclei. And in the last on the right here, it's cancerous because what's happening is now it's spreading into the surrounding area. So there are different stages in the development of cancer, from normal cells to cancerous cells. And along the way, there are steps that may lead to reversion back to normal. It's more likely to occur with hyperplasia than with dysplasia, but that always depends on the tissue type, on where the cancer is, and on the person's how they want to treat their test results. As healthcare consumers, you might be somebody who, if you may find hyperplasia as a test result. For women, that can occur with pap smears, that the cervical cells may come back as hyperplastic. And if you're somebody who can be what's called a watchful waiter, or somebody who can, I guess they also call it active surveillance, who's willing to go back every 3 to 6 months for another test, then you may see, that may be how you choose to treat this diagnosis. Somebody else might decide that any changes are too much for them and they just want to have it removed, and they want to have a biopsy to see, is there more cancer cells, or just take it out. This can also happen with women in breast cancer, that they may see that there's with a mammogram, that there's an abnormality. An abnormality just means it looks different. Abnormality in this case is very scary sounding, but it just means that something was found on a mammogram. And then once they biopsy, they can then tell whether it's hyperplastic or dysplastic or cancerous. Anecdote alert, I've had several instances where I've had something show up on a mammogram, and I used to just want everything out, and I did. And luckily for me, it was normal. But then I realized that maybe I can become somebody who can participate in active surveillance. And so I went back like every 6 months for 2 years. And luckily for me, it never progressed. But dysplasia is higher risk. All right. So for me, at least, if they found dysplasia, I'd say take it out. So what we're talking about here are the changes that occur from normal cells onto the development of cancer in tissues. Questions about dysplasia, hyperplasia, benign, malignant? What I'm not asking that I used to ask is, does anyone know a person who's had cancer? Now, probably a more realistic question would be, are there any people here who've never known anyone with cancer? Because it has become so common. But what I've also learned is, because there are so many types of cancer and there are so many screening tests, that people find things. That's what I should have asked. What kind of consumer do you think you are? Would you be able to be a watchful waiter, or would you be a take it out? Does anybody have any idea of what kind of consumer they think they might be if something was found on a screening test? And it's okay. And you're allowed to change. All right. And I guess it's okay as long as you have healthcare and support, because we all go through stages. I like to tell folks I'm a recovering hypochondriac, because I used to want to treat everything, and I thought that was how I had to be. I'm not that person anymore, but that's me, and I'm a lot older. I have friends who are being tested for everything, and I have people who don't worry. Everybody's different, and I think I've learned that there's no right answer depending on the situation. But again, as healthcare consumers, you will decide or find out what kind of healthcare consumer you will be. All right, so current events, Josh and Michael C. Are you there, Josh and Michael C? Are you with us today, Josh? Michael C? Going once? No? Anybody have anything they want to talk about? The weather?
Yeah, I thought I had mine today.
Well, then go. And then, yeah. Would you mind? Well, I'll go back and check the list.
All right. Well, I read an article about the first rapid at-home COVID-19 test. And so the FDA approved it on November 17th. It
Mhm.
was last Tuesday. So it's just like a swab your nose, stir into a sample, and the website for it's called Lucira, and their website said that you could get results in as little as 30 minutes. But I read like an analysis of it, which said 3 to 5 hours to get some kind of indication
Mhm.
if they have COVID or not. But so you can't just like order the test. You have to get a prescription from your doctor. You have to be they suspect you've contracted it. And it's also authorized for doctors' offices, hospitals, urgent care centers, and emergency rooms.
Mhm.
So the test allows individuals to test themselves at home, claiming that the tests are 94% sensitive and 98% specificity, and they're supposed to be 90% or above accurate.
Mhm.
And there's two test kits. One is the antigen test to detect specific protein patterns from the virus. They're faster, but can have like less chance of being accurate, and also a greater chance of missing active infection. Then there's some molecular tests which detect genetic material from the virus and have a significantly reduced risk of false negative results.
Wow, I just realized I wrote down the names for last week, not today. So Robert, I see you. So what do you think about the test?
I mean, like it's only been out since like last week, so I mean, I'd probably have to like read about it more and see like if people are like using it and what their results are all about. But
Mhm.
I mean, the analysis and on the actual Lucira website both claim to have above 90% accuracy. So and they also said, which was like sort of confusing, that they've been in the process of creating the test for over 5 years.
Huh. An antigen test or this antigen test? Because we've only known about COVID since, the beginning of the year.
Yeah, exactly. It's for these antigens.
Okay, so maybe they've developed a mechanism for testing
Yeah,
antigens, and this was the one that wound up being the best one to use it for right now.
yeah.
Yeah. So that's interesting. So keep in mind that, it had to go through the gauntlet in order to get to where it is now. So it has been tested on a number, on a number of people, but when it goes to
Yeah.
market, then the number of people that get tested will increase dramatically, and that's where post-approval marketing or data collection become really important. Okay, thank you. Robert, do you have a current event?
Yeah, I do. So,
Thank you.
yeah, so they're saying that as early as December 12th, we could have a few vaccines available. And, well, there's a big question I mean, obviously you have no legal obligation to take a vaccine, any vaccine. And there's going to be very limited access to this vaccine. And they're saying that healthcare workers and frontline people are going to have the first access to it. But so for the article I found, they took a poll. Let's see, what was it? I think it was the hold on, sorry.
That's okay.
Yeah, they took a poll. The American Nurses Association, and they found that more than 66% of healthcare workers, they either said that they don't plan on taking it,
Hmm.
and then the other half, it was pretty much 50-50 between that 66%, and the other half said that they're not sure. And then also with this, what's happening is hospitals and even the CDC are thinking of even making this required for frontline defense people. So I was just wondering what everyone felt like. How does everyone feel about that?
About taking it, not taking it?
Yeah, because
I
obviously
know.
we have our nurses who are hesitant because they don't want to be quote unquote like the guinea pigs of it,
Well,
especially with how quick this vaccine has come.
so it's not because they're anti-vaxxers? It's
Yeah,
Is there? Okay.
They're just not sure about how well it's going to perform.
I know I personally think that, and this is my bias, if Anthony Fauci gives it 2 thumbs up, then I'm okay with it. I'm not a frontline person, although I don't know that I'm also, I mean, I'm at higher risk for various and assorted reasons, but I'm also not a frontline person. And I think that those are the folks, and teachers, you know, people in elementary schools, those should be the folks that are, you know, our teachers are on the front line, and so that they should be the ones that should get it. But you're right. I don't know if they're going to be working in a hospital situation and they're exposed.
Yeah, it's a tough situation for both the frontline workers and just for citizens, really.
Yeah. What does anybody else think? Okay. Garrett, are you going to get the vaccine available?
Probably not.
Why not?
I'm just a little wary of it. It's not like I'm like certain I won't, but like just as of now, if I had the option to take it, I probably wouldn't.
Are you, if I may ask, social distancing, wearing a mask, and washing your hands regularly?
Yeah.
Okay. Because those are, in addition to a vaccine, those have been shown to be quite effective.
Yeah.
Okay. Avery, how do you feel?
I'm probably not gonna get it right away, but that's because of I mentioned before how my sister got transverse myelitis from the Gardasil vaccine. So we're just a little bit more worried and want more information before we do vaccines, and like this is new, so we want a little bit more time before we would do it. And that's what I feel. I'm not sure how the rest of my family feels, but that's generally how we feel about things. Like we're not anti-vaxxers. We just want a little bit more data first.
Hannah, what do you think?
I will probably get it when it's available.
Mm-hmm. Yeah. Sarah, what do you think?
I would want to like get it eventually, but I'd want to wait and see like the effects of it, I guess, on people first. Like I don't want to be the guinea pig, I guess you could say. But like my mom is a healthcare worker, so she'll probably get it before me anyways. So I feel like once I'm fine with that, I'll be like, okay. Like I don't think they're gonna let us go back to school or like jobs or anything without getting it. If you work in like companies or something like that. So there's that too.
I want to get it so I can start traveling again. That's how I feel. Malcolm, what do you want to do? You're young and healthy, or aren't you? No, it's none of my business. Are you? No, none of my business.
I already had the virus, so I think that I'm good for hopefully 90 days right now. We'll see what happens if there starts to be a bunch of mutations. I guess the virus won't help us, or the vaccine won't help us anyway. So I don't know. I'm just going to wait it out right now.
Have you been tested for antibodies?
No, I tested positive through Bentley like a month and a half ago, and then I lost all taste and smell. So I think I definitely had it.
Yeah. And that's what I'm curious too about folks that have had it, about the antibodies and how long they last. What I did hear about one of the vaccines, maybe I said it to you guys already, was that it might have what's called superhuman response. And it doesn't make you run faster and jump higher, but it means that the response, the antibody response, is greater than if you would have been sick yourself. So, for example, the measles vaccine has a superhuman response, meaning that the benefit of the vaccine is greater, the antibody response is greater than if you actually had measles. So depending on the vaccine, I certainly understand everybody wanting to wait. I am okay with getting it when it comes around, but I don't think I deserve to have it before other folks because they are more frontline and deserving at this stage. So you guys just have to sign something that says you will continue to maintain social distance, wash your hands, and wear a mask, or you will not have any health care when you get sick. It's that simple. All right. Thank you. Thank you, Robert. Okay, let's see. What do I have? Okay, so current events was not Josh and Michael. wherever Josh went. Oh, I got this in my email today, sets, just to remind you. I will say that having asked you to do journals regularly has been helpful for me, very helpful in terms of knowing before the end of the semester how you all thought about the class. But there, I've done my due diligence. Okay, so I didn't have anybody post on the Padlet. That's probably the last Padlet for this semester. Engagement grade. Anyway, so I have 5 questions. And I'm going to put you in 4 groups. No, I'm still going to put you in, let's see how I want to do. I'm going to put you in 5 groups and help out the group that's the smallest, although I like to help everybody out, and give you about 5-10 minutes. So group 4 just totally left the building. Group 5 totally left the building. So I guess I'll answer that one.
I was group 5. Yep, we're.
Oh, you're back?
Yeah, we were just back in the main session. We finished.
Oh. Darn. Then I won't. Gee, I rearranged my slides just so I could. Okay, I apologize for thinking nasty thoughts. Okay, group 1. Oops, let me stop recording. You mean it's been on the whole time? You mean I didn't stop recording? I never paused? I guess I'm going to, okay, carry on.
Anyways, the lead time bias is basically the length of time between the detection of a disease and the time of the diagnosis. And basically what that does is it makes it look like patients of a disease are surviving longer because they got the disease detected earlier. However, like the survival rate would be the same, like the age at which they would pass away if they do pass away. So it basically, how we felt about our feelings towards it is that like kind of iffy because like it gives like false hope into like survival and stuff like that.
Oh, are you done? It's hard when you know statements end with your voice going up. It's just a okay, yeah. I actually let me just kind of since I did let me show them show the class what I showed you folks. Although so I've been recording the whole time because then it'll be in the recording. Is that what that means, Avery? Okay, I'm going to just do it anyway. I'll show you what I have because I think this is an important concept and we'll just confirm what Lauren was saying. So the example I gave in the video where you have 2 people going to Washington, D.C., one gets on the train in Boston, the other gets on the train in New York, and outside D.C. the train crashes. They both died at the same time, but it looks like Beth lived longer. So because she got on the train first. What does that mean in terms of diagnosis or bias? Here's an example of 2 people, if you will, that have cancer and died at age 70. Without screening, the person was diagnosed at 67 and died within 3 years. So what's called the 5-year survival rate, which is kind of something people ask about, how many people survive for 5 years thinking that means something huge, and it may. The 5-year survival rate for this person was 0. Whereas on the bottom, this person was diagnosed at age 60, also dying at age 70. So their survival was, 5-year survival was 100%. What does that mean in terms of living with cancer, living with being treated? I don't know. You know, the lead time bias means finding out earlier, but you don't know that until after, you know, after the person has died and you look at the statistics. So it's hard. One of the reasons why mammogram recommendations have changed is because it was found that people were living longer with breast cancer. And that mammograms didn't always diagnose a cancer that was going to kill somebody. The concern was that if you have a fast-growing cancer, it could appear in between mammograms, and that a slow-growing cancer, you would die from something else. The same thing is happening with the PSA test for men and prostate cancer. They're learning more about a fast-growing versus a slow-growing cancer. A slow-growing meaning that you will die of something else, and a fast-growing cancer meaning that your treatment may help, it may not. But that's things that men need to be aware of before they decide to have the test or when they're deciding to have treatment. There are a lot of movie stars and actors and famous people out there who had a PSA test and found they had cancer, and it was found early, and they are the ones out there singing the praises of PSA because it worked for them, because it saved their life. That doesn't mean that everybody should be having a PSA test at every doctor's appointment, but you have to make that decision for yourself. The same with mammograms. I think I told the one group, my doctor was telling me, well, you're at high risk, you're an Ashkenazi Jew, you have a family history, you haven't gone in. And I'm like, I know all this. I also know that I've had a lot of false positives, and I take responsibility. And I'll schedule one when I schedule one and put it in my notes so that you don't, I won't come back and sue you for not telling me. But so lead time bias, it's kind of significant in any number of things, but with screening tests, just knowing, are people living longer because of treatment or because of lead time bias? That's, I guess, the bottom question. All right, next. Who's next?
We said that if someone we cared about had a positive result, we would advise them to make the best decision in their interest, especially if they have health care coverage, and to weigh out the pros and cons of getting the tissue removed or not. And it really depends on how abnormal that tissue is. And we also would suggest that the person should continue doing follow-up tests if they decide not to remove the tissue initially.
And may you never have to make that decision. May that never, but that's where, the idea is that you try to make your decisions out of facts and not fear. But if you make it out of fear, that's who you are at that moment. And it doesn't mean that it'll always be that way. So you do what's best for you. Okay, who's next?
So we have the next one, and basically we said that apoptosis, I think that's how you say it, is just programmed cell death, and then cancer happens when one of those cancerous cells doesn't get the message to die or perform apoptosis. And then angiogenesis is the development and growth of new blood vessels, and cancers can spread through receiving oxygen and nutrients from those blood vessels, which helps them to grow and spread throughout the body.
Okay. I suppose that one of the differences between hyperplasia and dysplasia might mean that the cells are late to getting the message to die, because hyperplasia is an increase in number of cells, but they haven't yet started making the malignant changes that are more likely to occur with dysplasia, or not. So that, because apoptosis means programmed cell death, and our cells have them. Red blood cells last about 3 to 4 months. The cells in your stomach or in your mouth are about 3 to 4 days. Let me just ask you a question. What have you all heard are some of the side effects of chemotherapy?
Nausea.
Nausea.
And vomiting.
Vomiting. What else? The folks, have you heard?
Hair loss.
Hair loss. Right. And those are cells that rapidly divide. All right. The cells in your mouth sores, there's a name for those, or your stomach cells divide, your hair cells divide more often. And so what cancer treatments do, well, what chemotherapy does, and we'll talk more about this next class, it's a systemic treatment in that it travels through your blood, and it affects rapidly dividing cells, and cancer is a rapidly dividing cells, but we also have these other rapidly dividing cells. There are other treatments that I talk about in the video that are more targeted treatments that hopefully will reduce the risk of developing these side effects and will only attack the cancer cells. That's what monoclonal antibodies may do. That's what some other targeted treatments may do. But something like chemotherapy affects rapidly dividing cells, and that's what leads to some of the better known side effects. Yeah. Okay. Very good. Next. Who's next?
So we have the different different drivers of cancer, and the first was proto-oncogenes, which are involved in normal cell growth, but once they're mutated, they can become oncogenes, and that can lead to cancer. Tumor suppressor genes are also involved in normal cell growth, but when those are altered, they're no longer able to suppress growth, and this can allow cells to begin dividing in an uncontrollable manner and lead to cancer. And then the third type was DNA repair genes, which normally fix damaged DNA, but cells with mutations in this gene tend to develop mutations in other genes, which can cause you to have increased risk of cancer. And then the BRCA mutation that we talked about is a tumor suppressor gene driver. And if we're developing a drug to target tumor suppressor gene driver, we'd want it to be able to regulate the cells and prevent them from being altered. And since tumor suppressor genes control the growth of cells, the drug could also work towards itself regulating, being a regulation system, or also helping, like just having two different things, being the regulation system and as well as helping the regulation system in place to make sure that's still functioning properly.
Very good. I had no idea when I asked the question, so kudos. All right. Carcinogenesis, people who are here.
So our question was for the carcinogenesis, and this is the process which normal cells are transformed into cancer cells. It has 3 stages: initiation, promotion, and progression. In the initiation stage, carcinogenesis results in irreversible genetic alteration, and it's most likely simple mutations, transversions, transitions, or deletions of DNA. Factors that can cause this are things such as UV light or environmental factors. Its promotion is the continued introduction of cancer-causing factors. This is the reversible stage of promotion. It does not involve changes in the structure of DNA, but rather in the expression of the genome mediated through promoter-receptor interactions. And then once you get into progression, this final stage is irreversible. It's uncontrolled growth of the abnormal cells that have been developed. And this can lead to malignant tumors because the abnormal cells will spread through the bloodstream and go to the brain from places in the body that are already infected with cancer.
Okay. And where did you get that information?
From the PowerPoint and one of the articles Josh found.
Okay, good. Yeah. So and for exam purposes, if this would come up in an exam, you don't need to do outside research. What you have, what I gave you was sufficient. Okay. So let's see. Any questions? All right, let me just see. I can't get my mouse. Oops, nope, that's not going where I want it to go. Okay, let me just see if I have anything that I want to, before we go. No, okay. Be safe, folks. Take care of yourselves. Thanks for coming to school today. I'll see you next time.
Good Thanksgiving, Professor.
Bye-bye.
Have a good Thanksgiving.
Y'all too.
Thank you, Professor.